diabetes. We've talked about this for the last 6 to 7 years with all of the advances that have been made in diabetes care. It's really phenomenal. And I think about my own time when I was in private practice for 13 years, how difficult it was to keep abreast of the most up-to-date information on anything, much less a specific topic like diabetes when you take care of so many things. We really felt like it would be a fun thing to do is to start an echo focusing on diabetes and the advances and how we can enhance patient care because so many of our patients have diabetes and other things. So it's really just the tip of the iceberg to help us enhance patient care and outcomes. So lots of advances in the last 30 years in particular, but even in the last 15 years, we've seen some big strides. So what we've learned, and I think it's really funny, many people well, heck, there's not many people on this call that have been in practice as long as I have. So I was going to say, if you've been around any amount of time, you figure out that a lot of people didn't think much about diabetes and pregnancy in years past, particularly gestational diabetes, didn't think it really mattered. And it wasn't until the 2005 or so that people really started to give it attention. But we've learned that diabetes of all types, type 1, type 2, and gestational, have huge impacts on both the health of mom and baby for the future, not just during the pregnancy, but far beyond the pregnancy. This is a fact sheet from the CDC from 2023, and the numbers are quite remarkable. The big one there in the octagon, 40 million is the estimated number of people with diagnosed or undiagnosed diabetes in the United States. I mean, that's tremendous. Um, 12% is the estimated percentage of the US population with diabetes. That is huge, over a tenth of our population. 29 million is the estimated number of people with diagnosed diabetes in the US, and almost 28% is the estimated percentage of adults with diabetes who are not diagnosed. And that's a huge population that will make a huge difference in management and outcomes if we can reach that group of people. And pregnancy prevalence of diabetes, almost 10% of our South Carolina pregnancies are affected by gestational diabetes. That's a large number. And approximately 2% of South Carolina pregnancies are affected by pregestational, either type 1, but more commonly type 2 diabetes. And these are graphs showing the trend of the incidence of type 1 and type 2 in children and adolescents, which is huge and will become hugely important as we spend more time together on these diabetes echoes to help understand the impact of diabetes exposure in utero to the future risk of diabetes in these children. Type 1 diabetes really hasn't increased a great deal over the years, more common in Caucasians than in Blacks. But type 2 diabetes, you see a significant increase in that trend line between these 10 and 19-year-old individuals. And it's directly related to lack of activity and increased body mass, but a huge impact. And the discrepancy in races is quite significant, as we'll show on the next slide. If you look at the top right-hand corner, the prevalence of diabetes is higher among Black adults, 17% more than white, which is about 12 to 13%. And non-Hispanic Blacks have 2.5 times higher age-adjusted death rate compared to non-Hispanic whites due to diabetes. This is a graph from DHEC back in 2021, so the numbers are old, but they're very similar today. If you look at in 2021, South Carolina had the sixth highest percentage of adult population with diabetes in the United States. That's a tremendous number. And when we were looking at starting our clinic, we learned some sad statistics where our hospital sits at Richland Memorial in that zip code. We have the highest percentage of amputations from chronic diabetes conditions than anywhere in the United States. So it's a tremendous problem that we have here in our backyard, literally. And it affects pregnancy tremendously. This is a chart from March of Dimes, who we also partner with. We have the great distinction of having a grade of F for preterm birth grades in South Carolina compared to the rest of the U.S. The rest of the U.S. is not great. It's at 10.4%. South Carolina was 11.6 back in 2022. A little bit better than the year before, but nothing to brag about. And unfortunately, in Columbia, ours is even worse at 12.6%. So we've got a lot of work to do. And the disparity continues in every little realm we look at. And that's the same in preterm birth, that Black birthing moms have a 1.5 to 2 times higher rate than other moms giving birth to babies. So this is a busy chart, but I think it's important to spend just a minute on it so that everybody gets the difference between the types of diabetes and the impact on pregnancy. But the first purple row has to do with type 1 diabetes. It's primarily an autoimmune destruction of the beta cells where little to no insulin production is taking place. It's always been called juvenile diabetes, but it can occur in adults as well. The onset is generally sudden and rapid, and it's lifelong, and it requires aggressive management and treatment with medications such as insulin to make a difference and enhance life outcomes. In pregnancy, this is the type that frequently is associated with an increased risk of birth defects, significant birth defects, large babies, small babies, higher risk of C-section, birth trauma, and then neonatal complications and even stillbirth. Type 2 diabetes, outlined in the light green, is more of an insulin resistance. It eventually evolves into a deficiency of insulin, but it's more of a resistance to start with. Um, and generally, there can be very high levels of insulin to start with. It happens gradually, and the onset can be slow, and it can be treated really with aggressive diet, with oral medications, and sometimes we have to use insulin, but exercise helps, weight loss helps. Um, it's rarely believed to be reversible. I tell people with significant weight loss, we can see patients go into remission, but they always have it, and it can come back with some weight gain. That insulin resistance is there. It can be associated with the same things in pregnancy. It can be associated with birth defects if those blood sugars are high. Um, it's also associated with the big babies, the growth restriction, and the same other things with type 1 diabetes. Gestational is different. It acts like type 2 diabetes, but it's really uncovered in the pregnancy. The hormones of pregnancy uh, really take people who are predisposed to diabetes and pushes them over the edge. Many of these patients can be treated with diet, exercise. Sometimes we have to add insulin. We'll get into a little bit of that later. But it usually resolves after birth. Now, these moms are at risk later, but it generally goes away if it's truly gestational diabetes. These moms don't have so much of a risk of birth defects, but they do have all of the neonatal complications and birth trauma, things that you can see, and it can affect mom's life long term. And this is just an interesting slide for an old guy like me who's seen so much of the progression from the years going from White's classification that really looked at stratification. It was a stratification system looking at how diabetes was associated with poor outcomes into the O'Sullivan and Mahan GTTs and development of the diagnosis of gestational diabetes. I want to point to the very middle of the slide. In 2008, the HAPO published trial was really eye-opening for those in academic medicine that got everybody's attention that, yeah, gestational diabetes does matter. Because before that, we were taught it really didn't matter much. I don't know why we're going to so much extreme to diagnose gestational diabetes, but it does matter. And then the criteria of using either the two-step or the one-step method to diagnose. As we've gotten more and more into care for our diabetic population and pushing our providers and our teams to look at the recovery from gestational diabetes after delivery, we have noticed a huge care gap where we're not following up our gestational diabetics after delivery, and they're not getting tested to see if the diabetes goes away, and they're not getting that long-term follow-up. This slide says less than 20% receive follow-up testing. In many studies, it's less than 5%. So it's a huge care gap that we have. We have so many new technologies that we want to get into. And the last thing is the team-based care model. We have it labeled 2023. It's been around for a lot longer than that. We kind of adopted it in diabetes care here in South Carolina around 2019 and started it up in 2020. Our South Carolina moms team was put together to improve care and access for diabetes in pregnancy. We have partners at Prisma Upstate, Prisma Midlands, MUSC Health in the Low Country, and our diabetes care for healthy pregnancy. And you can see on the next slide, the collaboration is crucial. You can see on the left-hand side is the funding that we have already mentioned by Michaela. On the right are the partnerships that we have, the Midlands and Upstate. We have partner with Midlands, Healthy Start, Food Share, March of Dimes, and in the Low Country, MUSC partners with Diabetes Initiative of South Carolina. So South Carolina Moms is truly an initiative designed to improve outcomes for pregnant moms with diabetes through a coordinated, but more importantly, patient-centered model of care. And that's the key. It was launched by Dr. Lyons and his team at Diabetes Free South Carolina. He really had this vision for a long time and came alongside our special teams in 2020 and started these clinics, expanded in 2025, and now we've really grown, and we'll talk a little bit about that. But the multidisciplinary approach, bringing us all together in one site, has been critical to the success of our program. To date, our partners at MUSC and Prisma, we have seen over 3,500 women through South Carolina Moms, so a huge impact already. This is a map